Okay, I guess this is part 3 of imaging the heart. This one's going to go relatively quickly. There is a number of different imaging modalities presented here besides regular radiography. And we just barely started looking at the relationship between the pulmonary arteries and pulmonary veins and the bronchi. So I'm going to pick up there. This picture that you're seeing right here, I get it, it's rather busy, but it's a really nice one for showing you the interaction or the interrelationship between the pulmonary artery, which is what you see there in blue, and the trachea and the bronchi. You have that pulmonary semilunar valve, and what this is sort of implying is it's coming from the anterior and it's going back posteriorly. So really this is the pulmonary trunk. Then it splits off, and each pulmonary artery is going to be heading towards its respective lung. So you've got the right pulmonary artery, and notice it runs along essentially with the mainstem bronchi here. And then you have the left, which is kind of shorter and actually projects back more posteriorly. So it's really kind of in behind. But the fact of the matter is that they're sort of draping on top of one another. Now you have two pulmonary arteries, and that's in keeping with the usual ratio of a 2-to-1 between arteries, I guess you say between veins versus arteries. So the next picture right here is actually showing you the pulmonary veins. And again, these are going to be located further inferior than the pulmonary arteries. I'm going to back her up again. You can see with the pulmonary arteries here with relationship again to the two bronchi, the right and the left bronchi. These are down lower. But they are kind of interrelated, because whereas the pulmonary arteries and the bronchi are entering, I guess you would say, into the hilum of the lungs, in the side, the pulmonary veins in essence are draining away from the hilum of the lungs towards the heart. And in fact what you actually have, if you keep in mind from all of this, sitting right here is going to be the left atrium, because that's where these 4 veins actually drain in. So you've got 2 arteries and you have 4 veins. Now I think I mentioned this last time, it's worth mentioning again. The correct definition for an artery is a blood vessel that moves away from the heart. The correct definition for a vein are blood vessels that move towards the heart. So the pulmonary arteries are leaving the right ventricle and heading towards the lungs. The pulmonary veins are leaving the lungs and heading towards the left atrium. Now, as I mentioned, they project from anterior to posterior, so we're into an axial. Now that means this is anterior here. You can see way back in the back side here, there's the vertebral body. So this is where the patient's laying on their back. Now they've put iodinated contrast media into this person's system, and that contrast media is what's showing up and enhancing here. This is the pulmonary artery. From here, essentially kind of flowing back this way. So it's going from anterior, it's flowing back posteriorly. And from there, it's going to split off into the 2 arteries. So, for example, we've got it heading over here to the right, and then you have it heading over here to the left. Now, you may notice that there's these gaps in the contrast media in both of these vessels. Let me clear this off again. What you are seeing there is evidence of blood clots that are lodged in the pulmonary arteries. That's a pulmonary embolism. Now an embolism is simply something that is relatively stationary, and is something that's moving. So for example, you could have an air embolism, you could have a fat embolism, but in this particular case we have a pulmonary embolism. Now the source of this blood clot could be from, for example, the lower extremities if somebody had thrombophlebitis. So there is a direct correlation between patients that suffer from thrombophlebitis, inflammation of the lower veins, and somebody that gets a pulmonary embolism. What's happening is that the clots will break off and they will flow towards the heart, because that's what, after all, venous blood does. So it'll end up, say for example, in the inferior vena cava, into the right atrium, right ventricle, and then here. And essentially it's going to stop here, because at this point these vessels are going to start subdividing as they head towards the hilum, and that's where these things plug up. Okay. Now, the other possibility that you could develop a pulmonary embolism would be, for example, if somebody had atrial fibrillation or atrial flutter. What we're talking about is incompetent compression at the atria. It may be either just kind of fluttering, so that it's just sort of the blood is sort of sitting stationary and not flowing properly from atria to ventricles. And if it happens on the right side, then you could potentially have clot forming there. The clot would move from the right atrium to the right ventricle into the pulmonary arteries, because that's the normal flow. Okay? All right. Now, if you have something like we just showed you, where you've got clot, and let's say, for example, you've got a nice blood vessel coming along here, and you end up with a big old clot lodging in here. Okay? Under normal circumstances, flow of blood is supposed to be going this way. Okay? Well, in this case now, there is no flow here. So we've got pressure here, and that pressure is going to increase on this side, and we have no pressure over here. It's at zero. Okay? Because things start doing this, and because it blocks up, you're going to develop, in a sense, a higher blood pressure because of the resistance. And believe me, this clot forms a resistance. That's exactly what's happened here. Now, you can develop pulmonary hypertension because, for example, somebody has extensive pulmonary embolisms. Once you go to work and block these things up, then everything starts backing up, and you can develop pulmonary hypertension. It is also possible to develop this, for example, for somebody who has emphysema, where there is such extensive expansion, overexpansion of the lungs, that honestly nothing's working very well at all. They can develop it too. Now, between the two of them, pulmonary embolism versus something like emphysema, I want you to consider a pulmonary embolism is going to be an acute episode. People don't typically have chronic problems like this. Okay. On the other hand, emphysema is about as chronic a condition as you can possibly get. In fact, it's chronic and it's progressive. To have images like you're looking at here requires a certain amount of development time. Okay, the body has to respond, expand, because of the backing up and backing up and backing up. So my money's on the reason, for example, something like this happening would be something chronic rather than something acute. Now, what's the problem here? Well, believe it or not, this is the right atrium. By the way, I want to point something out to you here, guys. There's midline. All right, here's the right ventricle. And there's the left ventricle. You have the pericardium surrounding it. Now, if you're not familiar with the pericardium, I suggest you kind of go back and check one of your anatomy books, but it's a fibrous sac that encases the heart. It's fibrous. It can stretch to a degree. I like to use the analogy of Spanx, and so it'll stretch to a degree, but at some point it's not going to stretch anymore. But the inside of the heart continues to expand. In other words, the chambers of the heart are dilating. For example, that right atrium there is huge. The right ventricle is actually pretty doggone huge. The left ventricle, on the other hand, is squished. Now, the reason the right atrium and right ventricle are huge is because you've got a backup in the same idea as what I just showed you previously. So now there's too much blood in the right ventricle, there's too much blood in the right atrium, back for so on and so forth. There's not enough blood in the left ventricle because it's being squished. The pressures there are actually, in a sense, lower. Remember something now. I said there's no pressure here. That also means in a lot of respects there's no blood. Okay? Now, if there's no blood going forward, then your body now develops ischemia, or the lack of blood supply. And then you have to have the issues that relate back to that. Okay, we'll go with that. Let's talk about coronary arteries. And in the United States, the most common heart disease is coronary artery disease, and probably has a lot to do with, frankly, the way we eat and our sedentary lifestyles. Interestingly enough, the most common disease, cardiac disease in the world in general, is going to be valvular disease, a lot of which has stemmed because in the past people had, for example, I think it's scarlet fever. They'd have strep, and it takes a long time for it to happen, but vegetation, that's the term that they actually use, vegetation begins to grow on the valves inside the heart, and they become very, very stiff and kind of non-flexible, and as a consequence, you end up with valvular disease. But in the United States, it's coronary artery disease. And so this has become big business, as you kind of see. Please understand something. For as many years as I have taught cross-sectional anatomy, for example, it is only relatively recently that I've really spent any time at all on coronary arteries, mostly because people didn't image them all that much. If you're looking at it from a superior aspect, and now from a superior aspect, what I really want referencing is the middle. The origin of the coronary arteries is going to begin with the aorta. That's where the branches come off. And specifically, the right coronary artery is coming off at about 10, okay? And the left coronary artery is coming off at about 4. Now, on the graphic that you're seeing right here, the right coronary artery here sort of seen between the right atrium and the right ventricle. It kind of goes around, goes on the inferior surface and around back on the posterior surface. Over here, this is actually the left coronary artery right there. It's relatively short because it's going to subdivide into a circumflex, which is going to go around back posteriorly, and the left anterior descending. This is just another name for it. Most of us know it as the LAD, left anterior descending. This one, as you can see here, is in between the right and the left ventricle, so it's sort of running along with that interventricular septum, and a big part of the flow that feeds the myocardium is coming from the LAD. When you look at an image like this, then keeping in mind that we're always talking about a three-dimensional object, but in a lot of cases we're looking at two-dimensional images. Now this is actually what's called a volume rendered image. What they did here, guys, is a kind of a combination of selectively picking out data from a CT, and that data is only the data from high Hounsfield values. In other words, contrast media. So that's really what you're seeing here, it's just contrast. Here, for example, is the aorta. And you can see we've got a vessel coming off here. That is your left coronary right there. And then it subdivides. And it's going to subdivide, remember, like I said, into the LAD, which is right here, and this one back in here. Now, you can't really appreciate the fact that this is going around back posteriorly. I know you kind of have to take my word for it, but it is. Remember what I said? This is a three-dimensional object, but we're talking about a two-dimensional image. This vessel that you see right here is the right coronary artery. And the truth of the matter is I know it just because that's what it looks like. So, what we do to diagnose where coronary artery is concerned is kind of multifold. Originally, what we started out with was coronary arteriograms, wherein they would thread a catheter up through the aorta, and they have to go this way now, okay, through the aorta, up, and to the origin, and then they put the catheter so it was aiming this way, or that way, depending on which one they were interested in actually doing, and they would inject iodinated contrast media in. When they injected the iodinated contrast media in, and by the way, there's the catheter right here and right here, they would fill the coronary artery, much as you see here, and its attendant branches. And what they were looking to see is that you had any evidence of obstructions, stenoses, anything like that. They'd also be looking for what they call collateral circulation. And the way I kind of compare this, if you consider the connector, which is really, for me, just outside here, if the connector is really, really backed up, then people are going to move off the connector into the parallel streets on either side. So, for example, if the connector is held up, you would expect that Metropolitan is going to get really backed up because people are trying to get by wherever the plug is. That would be the example of collateral circulation. In my case, we're talking about vessels, arteries, okay? In that case, we're talking about collateral streets. Now, in regards to coronary artery disease, what we're specifically looking at in a lot of cases then is atherosclerosis. Now, there's two different words. Atherosclerosis is really referring to fatty. Athero means fatty, deposits. Now, the dynamic behind this is that this fat builds up in between the muscle layer in the blood vessel and the inner lumen or intimal layer. There's actually three different layers. The outside is the adventitia, then you got the muscle, and then you got the inner intima. Now, the intima normally is super smooth. And the big reason for that is that as you have all these different blood vessels going through, you want them to go through intact, especially platelets. If platelets start breaking up, then you start forming clot. Well, we don't want clots to form just any old which way. But what happens, unfortunately, with these atherosclerotic plaques is that inner intima starts getting rougher and rougher and rougher. Because of this, the probability that you could develop a blood clot there, okay, or a thrombus, increases. Now, there's two possibilities for something like this. If the thrombus stays there, you could block the artery off there. That means you're going to lead to a reduction in blood flow, ischemia, and a reduction in oxygen, hypoxia. And if this goes to the myocardium, you end up with severe chest pain, which happens to have its own unique name, angina pectoris. Okay, it's supposed to be pectoris, not pectoralis. You develop angina when the ischemia really kind of, I guess you'd say, becomes apparent, because the starved heart is not getting enough oxygenated blood. And the heart always needs oxygenated blood because it's always moving. So if you look at the kind of dynamic here, atherosclerotic arteries have that rough inner lining. So this area in here is getting rougher. And you can see that was buildup. And this buildup here is the fat deposit. And like I told you, now what you also get is kind of like this reactive cellular formation, which isn't helping at all. And like I said, it gets really roughened, clots form, and then literally can take over the entire vessel. Or the other possibility is it can break off. Now if it breaks off, it is going to travel further downstream. So if the normal blood flow is this way, so we're saying the normal blood flow is here, okay, and something breaks off here, it starts flowing down. When the vessel starts getting smaller, let's say for example it branches off, and now this clot that we're just talking about here gets lodged in here, now you have basically an obstruction and you have the problem with ischemia, and then people have angina. The way we treat this is either through angioplasty or angioplasty and stenting. Now if you look at this here, we're talking about obviously adding a balloon in here. Angio means vessels. What we're doing is we're modifying it. Sort of like if somebody has a nose job, they have a rhinoplasty. What happens is that the narrowed vessel here, okay, now remember what's going on here now, you get the fatty plaque. Most of the time that fatty plaque is fairly pliable, unless it's really, really, really advanced, in which case it starts calcifying. But because this is fat, fat is fairly squishable. So what they'll do is they'll thread a catheter, okay, in the area there of interest. Now obviously they've had to x-ray and put contrast media to identify this exact spot. This catheter is a very special catheter, and they use it to inflate a balloon. So the doctor is on the outside, and he's actually inflating this balloon on the inside. When you do that, you can see what happens is it squishes the atherosclerotic plaque. It may also, by the way, tear the artery. That's one thing they don't want to have happen. Now, once they've squished it enough and they've opened the vessel, then they can remove the balloon. That's an angioplasty. Now you see things are fairly open here, so you can basically have blood perfuse. Presumably we're going in this direction further downstream. They don't do that as much anymore as they do an angioplasty with stenting. Excuse me. With stenting, they use a specialized balloon catheter that also has this metal mesh surrounding it. And this metal mesh can stay in a specific position. So they'll bring the balloon in, again, around the plaque. They'll inflate the balloon to squish the atherosclerosis again. that at the same time that they're opening up this balloon, they're also opening up this stent. What they'll do here is the stent, once it's open, stays in place. They deflate the balloon, withdraw the balloon catheter, and the stent stays right there. The idea behind this is to ensure that the plaque doesn't re-occlude the blood vessel. Now, these are supposed to actually be videos that are just not going to be videos, so let's kind of move on. Actually, I thought I had moved that. Here's an example of somebody who's had stenting actually done. This is the catheter right here, and it's going into the left coronary artery. And you can see we've got all kinds of issues going here, and as you know, this looks terrible and all. What they did presumably is to open things up perhaps in a number of places, particularly here. They may have inserted balloons with stents. It's a little tough to tell on these pictures here, but presumably they've stented it. Now once they've done that, they've opened these vessels up, so now blood can flow normally. And once it starts flowing normally, then you're going to expect to get filling of vessels, as you do here, for example, that you don't see here at all. So now there's plenty of blood getting to the myocardium. Now, kind of what I've been dancing around is this whole idea of a heart attack. And what I just described, if you had an occluded coronary artery, because of the ischemia, can lead to a myocardial infarction. Infarction means that the cells have died. One of the things that physicians have tried to do is to potentially predict when something like this could happen. And they have utilized CT in particular as a means for evaluating how much plaque, specifically calcified plaque, you find in these coronary arteries. They're looking at not only how much is there, the size, but they're also looking at how dense or how bright the calcified plaques are. The combination of the two of them there gives them a score that can kind of predict whether or not things can happen. Alright, we don't need this. Here's an example. Now this is an old image right there, and there's the right coronary artery, and believe it or not, there's the left right there. You're seeing it better over here. Now, on this image right here, there's the sternum, so this is anterior. They have injected contrast media over here into what is called the SVC, of the superior vena cava. Okay, the contrast hasn't got there yet, but this is the beginnings of the right atrium. You see how it looks a little bit like a finger? If the finger is pointing anteriorly, that's what it is the right atrium. Now directly adjacent to that we have the ascending aorta, and the coronary arteries come off of the ascending aorta, and in fact that's what you're seeing right here. That is the left coronary artery with a boatload of calcified plaque within it. Incidentally, what you have over here is your pulmonary artery. Here's another one, still with the SVC, right atrium, aorta, and pulmonary artery. That hasn't changed. You can see the vessel coming off here, the left coronary artery, and you can see the rather extensive plaque that is located within that left anterior descending artery. Now, this is an axial slice, but I just want to point something out. This is a very, very thick slice. Here's another one. This one is also fairly thick. Now, you can see here's the vertebral body. By the way, there's the descending aorta with a lot of calcified plaques on it. Here's the ascending aorta. There is the left coronary artery. And you can see we've got calcified plaque here, and it's very, very dense right in here. Now, one of the things that's probably happening here is this density here is blocked the left anterior descending, and what you are looking at are those collateral blood vessels I was talking about. Remember when I was talking about if everything's blocked on 75-85, then the flow is going to come over here to example metropolitan. And that's, I think, a lot of what you're seeing right there. That's collateral circulation. By the way, here's your pulmonary artery. So that hasn't really changed any. You're looking at a left coronary artery here, and for example, this is a CT scan, and you can kind of see there's a little bit of an evidence of stenosis here, And in a lot of respects, coronary arteries arteriography is probably still the gold standard. This one here is interesting as well, but for kind of a different reason. All right, this is the CTA, as you can see, and you're looking at the right coronary artery, and there's a stenosis. There's a really severe block. Because remember now, this thing is supposed to be kind of going like this and like that. Now, as a result, you're going to have a bit of backflow here. But they've also put a stent in here. This is a stent. Now, if they put a stent in here, then there had to have been a block here as well. What is interesting is what you're seeing there is one of those collaterals. This is sort of like Metropolitan Parkway versus 7585 right here. So some of this overflow is going in this way. That's kind of a telltale sign that there's something going on in here. Now, if you look at the heart cath, which is so, like I said, going to be the gold standard, okay, there is the block. So this is the same as what you're seeing right here, okay, so no problem there. There's that little branch vessel. You see that there. What you don't see on the CTA, and you do see on the cath, is that this blood vessel is generally narrowed. Okay, it's stenosing. It's supposed to be, I mean, it's broader here. One of the reasons why you've got this kind of collateral circulation going on here is because the blood's having trouble passing all the way through here. And that's kind of a bit of the answer as to why there's potentially something going on here. So seeing those collaterals can tell you that there's issues elsewhere. All right. All right, we'll kind of move past that. CABG, by the way, coronary arterial bypass graft. Now, this is an MRI, and you know, this is showing you the evidence of a myocardial infarction. You can see this is the left ventricle right here, and this brightened area right there has a lot of fluid in it and all. Generally speaking, when you have bright areas like that with fluid, it's going to be evidence of edema and a lot of heart damage. And as you see, the damage is pretty doggone extensive. When people have heart attacks, the myocardium in the area that's being affected will develop, as we just talked about, ischemia, or lack of blood supply, which leads to a lack of oxygen, hypoxia. If it's bad enough, the patient will develop angina, which is chest pain stemming from the ischemia. Now, if things really go south and the patient has a heart attack, okay, or we'll say a myocardial infarction. Let me be absolutely correct here. Okay. The cells of the myocardium will die because they're not being fed properly. They don't reproduce much. You know, we talked about this with regards a little bit to protection. Because they do not reproduce, they are going to be damaged long term. And one of the things that happens is that they become kind of soft and pliable. And one of the risks then is that you can develop an aneurysm. Now, an aneurysm is a kind of a weakening in the walls of an artery or a vein, or in this case the heart, that causes it to expand out or bubble. Now, these things can look literally like just a little bubble, or they can be the entire vessel just getting enlarged, much kind of like what you see here. When this stuff starts happening, there are significant changes going on, whether you're talking about the blood vessel or whether or not you're talking about the heart. Overall, because of this expansion, the vessels, the heart, are weakening, and you run a very, very real risk that they can rupture. So people have, for example, with aneurysms, ruptures. And you've heard of people who have had strokes, for example, because of an aneurysm in the brain. You could have an aneurysm in the aorta, the descending aorta in the abdomen, that ruptures. All of these things are possible. It may be different types of aneurysms, but the net result is the same. If they rupture, then the blood is just pouring into wherever it is you are, whether you're talking about, for example, the retroperitoneum or peritoneal cavity, or if you're talking about inside the cranial cavity, the results would be the same. This type of an aneurysm can do the same thing as well, because it's overexpanding and the muscle is damaged. Now, at some point, if it doesn't rupture, they can heal. But when healing occurs, Okay, what we would like to have is the replacement of the dead cells with like dead cells. But that's not what happens. In a lot of cases, what gets replaced is scar tissue. This is just connective tissue. And because it's connective tissue, it doesn't do what myocardium does, which is kind of expand and contract and self-regulate. It doesn't do much of anything. Because it doesn't do much of anything, it impairs the ability of the heart to contract, which means it's not going to push blood out nearly as efficiently as you would like. Here's an example. This is an MRI in an axial mode here. There's the vertebral body as always. And this patient, this is the right atrium, right ventricle. This is what's left of the left atrium. And going here, you get a huge, extensive ventricular aneurysm. Okay, and it's stemming from as much damage from the myocardium. Here's another one. This is a CT scan. So what you're looking at in this case is iodinated contrast media within the chambers of the heart. And you've got this huge kind of almost mass type effect here. And it's sort of like it's ruptured. In a sense, you've got a bubble, like a bubble in a tire, except it's in your heart. Okay, now let's talk a little bit about congestive heart failure. And let's see. Yeah. Let's start here and I'll back up. Congestive heart failure stems from the inability of the heart to move blood forward out of the pulmonary circulation and into the systemic circulation. Now, what do I mean by that? Well, consider this. Okay, we've talked about the flow of the heart. We were talking about it starts in the vena cava. Okay, and then it's going to go into the right atrium. All right, I'm going to have to go this way. Right ventricle. It's going to go into a pulmonary artery. And then it's going to go into a pulmonary, it goes into the lung. Pulmonary vein. Left atrium. Left ventricle. And left ventricle into the aorta. And on to the rest of the body. Congestive heart failure, or what we typically think in terms of, which is left ventricular heart failure, stems from the fact that the left ventricle is not able to properly push blood forward. And a lot of this can happen, for example, if somebody has a myocardial infarction or something that's interfering with the heart's ability to pump. Now, it could be a myocardial infarction. It may be something as simple as the heart rate has slowed down significantly. If this happens, though, okay, there's two things that are going to go on. You're not going to get enough blood going this way. At the same time, the blood that's supposed to be going this way gets backed up. Now, let's look at that first. From the left ventricle, it's going to back up into the left atrium. From the left atrium, it's going to back up into the pulmonary veins. Now, let's take a look over here. Somebody who has congestive heart failure will classically have a number of different signs, including engorged pulmonary veins, that's what you're seeing here and all, particularly in the upper portions of the lungs. So you get venous engorgement. Now, even from here now, from those veins, it's going to go into the lungs. And if the pressure is high enough, the fluid starts literally leaking out of the pulmonary veins and the little veins and things like that into the surrounding area. So now we have fluid in places around the lungs, in the lungs, around the lungs that's not supposed to be, which is why you end up with pulmonary edema. So this is happening secondary to developing CHF, or congestive heart failure. Okay, so it backs up. Now, in this particular case, one potential telltale sign is this kind of extensive fluid that's kind of backed up on both sides. The other thing is, don't be surprised if you don't penetrate the heart particularly well, because again, all of the fluid and things like that is just absorbing everything. Now I'm going to back up. Here's another case of somebody with pulmonary edema. Okay, and again, this is somebody classically you would expect would have congestive heart failure, although it doesn't say have to be. The heart is enlarged, from here to here, okay, because you suspect the right ventricle, right atrium's over here. So the patient's got cardiomegaly, enlarged heart, probably going to have congestive heart failure, which means we're backing things up from the left ventricle into the left atrium, into the pulmonary veins, and unfortunately kind of surrounding the lungs themselves. You can kind of see what the result of all of this is. When you have everything backing up like that, fluid accumulates because the pressure isn't allowing it to move forward, so it ends up basically getting pushed back. But it's kind of on the same idea. There's blood behind it pushing it forward too, so it leaks. And that's what you end up with here, is the alveoli and everything filled with fluid. Classically, if you walk into an emergency room, for example, and there's a patient there with pulmonary edema, you'll hear it as much as anything else. They will, of course, be short of breath, SOB. Okay? They may look a little bit cyanotic. They're certainly going to be anxious and gasping. But the thing is you hear the fluid. It's almost like they're drowning. And in a lot of respects, that's exactly what's happening. They're drowning. Now, if somebody has pulmonary edema, okay, the treatment for something like this is to give them a diuretic. Now, a diuretic is a medication that essentially opens up the valves, if you like, at the kidneys. So the patient will essentially pee more. Now, if the patient pees more, then they are dehydrated. If they're dehydrated, okay, the pressure will be off the heart to keep pumping forward because there's less fluid to pump forward. And as a result, it can relieve the pulmonary edema. Now, it's not necessarily going to do anything about the heart failure, but it can relieve the pulmonary edema. And classically, you can see somebody in the emergency room. You shoot the first x-ray, they're full of fluid, you can hear it. You might come back an hour and a half later when they've been given an injection of a diuretic, like for example Lasix, and they've been catheterized, they've poured out, maybe 1,000 cc's of fluid, and they feel much better because by dehydrating them, you've relieved this back pressure, you relieve the pressure on the heart. Okay? All right. Now, coming back to this here, there's another side to this whole thing. Because remember we talked about it, if the block is here at the left ventricle, then things are not moving forward, which means you're not getting enough blood to the rest of the systemic circulation. Because remember now, the aorta is going to take it everywhere else. It's going to go to the brain. It's going to go to the extremities. It's going to go to the trunk of the body. If you're not getting sufficient blood around, then for example, you're going to have part of this whole problem, which is the patient going to general signs of weakness, fatigue, anxiety, just like we talked about, because really they're starved for oxygen. They may be bluish looking, cyanotic. Some of the other things is that you may get a rebounding effect, because if the blood is not sufficient at, for example, the kidneys, one of the things the kidneys do is to help maintain blood pressure through what are called ACE, angiotensin conversion enzymes. Okay. Now you can go back and look this all up in your anatomy book and things like that. But one of the things the kidneys are responsible for is blood pressure. Now if you're not getting enough blood to the kidneys, then one of the things the kidneys do is respond by jacking up your blood pressure. Now you've got a heart that's already in serious trouble here because it's trying to pump and it's failing, and now you've got signals coming to it telling it to pump harder. Okay, needless to say, this doesn't work well. Okay, so all of this kind of gets down to what I was addressing before, which is the ejection fraction. Under normal circumstances, what we're doing is we compare the point where it's extreme relaxation to maximum contraction. We're looking for how much volume of blood is located in the heart, left ventricle specifically, during systole, versus how much is in there versus diastole. Well, obviously there's going to be more during diastole. In fact, what we usually find is the difference between the two of them can be somewhere on the order of about 50%. So about 50%, maybe 40 to 50% of the blood that's here will actually get pushed out and ejected into the aorta during maximum contraction. We call that the ejection fraction. Yeah. Okay. Now, that's a little bit, I mean, you can do ejection fractions through CT. You can do them through a ventriculogram like this. You can actually do it through nuclear medicine studies and all as well. Okay. I think I'm about done with this. And you're welcome to take a look at the rest of this, but quite honestly, I think we're kind of past this point here. You're looking at a beating heart there. This is actually like a thallium scan and a SPECT scan, MR. And I'm going to try to leave that alone here at that point because now we're getting way out. All right, we're done with this, and I will pick up with something else.